You have been told, directly or indirectly, that your double chin is there because you eat too much and weigh too much, that if you simply lost the weight, it would go away. You may have even lost weight, significant weight, and watched the rest of your body change while the submental fullness under your jaw stubbornly remained. You may have accepted it as genetics, as an inevitable feature of aging that arrived one year and decided to stay. What almost nobody tells you, and what the research increasingly supports, is that for a large proportion of seniors, the tissue accumulation under the jaw has very little to do with total body fat, and almost everything to do with a specific combination of structural, hormonal, and postural factors that operate independently of diet and that your bathroom scale tells you nothing about. This matters beyond appearance. The tissue that accumulates in the submental and submandibular region in seniors is not always the same type of tissue, does not always respond to the same interventions, and in some cases is a visible marker of systemic changes that deserve clinical attention. Understanding what is actually causing the fullness under your chin, whether it is submental fat, cervical lipodystrophy, lymphatic congestion, thyroid enlargement, or postural cervical forward head positioning, changes what you do about it and whether what you do about it has any effect at all. I am Dr. Edward. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. If your submental fullness appeared suddenly, if it is accompanied by difficulty swallowing, voice changes, or if you can feel a distinct mass or lump in the area, please see your physician for an evaluation before pursuing any cosmetic or lifestyle intervention. Subscribe to this channel right now if you are not already. Every week I cover the research that explains the symptoms and changes your body is going through in ways that most appointments never address. Subscribe now. It is free, and stay with me. Let me start by describing the anatomy of the submental region, because most people have never thought carefully about what is actually in that space between the chin and the neck. And understanding the anatomy is what makes the rest of this video clinically meaningful. The submental triangle is the anatomical name for the region beneath the chin, bounded by the lower jaw above, the hyoid bone below, and the anterior bellies of the digastric muscles on each side. Within this triangle, from the skin inward, you have the skin itself, subcutaneous fat in a superficial compartment, the platysma muscle, a broad flat muscle that extends from the jawline down over the neck and upper chest, a second, deeper fat compartment beneath the platysma, the mylohyoid and geniohyoid muscles forming the floor of the mouth, the submandibular salivary glands, the submandibular lymph nodes, the digastric muscles, and underneath all of this, the hyoid bone and its associated structures. Each of these layers can contribute to submental fullness in different ways, at different ages, for different reasons. The tissue you see under your chin is not necessarily fat. It may be any of these structures, individually or in combination. The first cause most doctors ignore is cervical forward head posture, the progressive forward migration of the head relative to the shoulders that occurs in a large proportion of seniors, and that has a direct and often dramatic effect on submental appearance. When the head is in ideal neutral position, the ear canal aligns vertically over the shoulder. In adults over 60, research using postural analysis has found that the average anterior head displacement is between 2 and 4 centimeters forward of the ideal position, in some individuals considerably more. Every centimeter the head moves forward of neutral increases the effective load on the cervical extensors by approximately 10 pounds and alters the geometric relationship between the jaw, the hyoid bone, and the neck. When the head protrudes forward and the chin tilts slightly downward, the characteristic posture of decades of desk work, reading, and increasingly screen use, the skin and soft tissue of the submental region is compressed and bunched between the chin and the upper neck. Tissue that would appear flat and defined in neutral posture appears as a fold or fullness in forward head posture. The tissue has not changed, the geometry around it has. A significant proportion of what seniors interpret as fat accumulation under the jaw is partly or entirely a postural artifact, the visual consequence of forward head posture compressing and foreshortening the submental soft tissue. This is demonstrable. Stand in front of a mirror. Press the back of your head against a wall so that your head is fully retracted to neutral. Observe the submental region. For most people, The apparent fullness reduces noticeably in this position. The tissue does not disappear completely. Some fat and tissue is genuinely present, but the postural contribution to the appearance is often striking. And unlike accumulated fat, postural contribution responds to postural correction. Cervical retraction exercises, scapular stabilization, thoracic extension mobilization, and the sustained habit of maintaining neutral head position can produce visible submental improvement in seniors without any change in body weight. The second cause is thyroid dysfunction, specifically thyroid enlargement or the accumulation of submental fat driven by the metabolic consequences of hypothyroidism. I described in a previous video the extremely high prevalence of subclinical hypothyroidism in seniors and the wide range of symptoms it produces. One of the consequences of hypothyroidism that is rarely discussed in the context of appearance is its specific effect on fat distribution. Thyroid hormone deficiency reduces the rate of fatty acid oxidation, the process by which fat is mobilized from storage sites and burned for energy. It simultaneously promotes the accumulation of a specific type of connective tissue infiltrate called myxedema, which deposits a gelatinous, poorly vascularized material in the dermis and subcutaneous tissue. This infiltration is most pronounced in the face, neck, and periorbital region, exactly the areas where hypothyroid patients characteristically develop the puffy, doughy appearance that is recognizably associated with the condition. The submental fat of hypothyroidism is not ordinary adipose tissue. It has a different texture, firmer, less mobile, less responsive to caloric restriction, and it responds poorly to exercise. Patients who develop submental fullness as a consequence of hypothyroidism and who then restrict calories and exercise aggressively may lose weight elsewhere while the submental region remains largely unchanged because the tissue is not ordinary fat responding to energy balance. It is myxedematous infiltrate responding to thyroid hormone levels. When thyroid function is restored to optimal, this tissue gradually resorbs. Without thyroid investigation and treatment, no amount of dietary restriction will address it. Subscribe to this channel right now if these connections are making sense. This is exactly the kind of research I cover every week. The systemic explanations for the physical changes seniors are experiencing and dismissing as inevitable. Tap the subscribe button now. The third cause is lymphatic congestion in the submandibular region. The lymphatic system is a network of vessels, nodes, and fluid that parallels the circulatory system and performs critical functions in immune surveillance and fluid clearance. The submandibular and cervical lymph nodes, clusters of immune tissue situated directly in the submental region, receive lymphatic drainage from the mouth, teeth, gums, tongue, and upper respiratory tract. In young adults with healthy lymphatic flow, these nodes are small, discrete, and not visible or palpable. In seniors, lymphatic function declines with age. The pumping action of lymphatic vessels, which depends on surrounding muscle contractions and body movement, is reduced by the same sarcopenia and reduced physical activity that affects other body systems. Chronic low-grade inflammation in the oral cavity, periodontal disease, dental infections, chronic postnasal drip, produces ongoing antigenic stimulation of the submandibular nodes, causing them to remain persistently mildly enlarged. The result is a diffuse, mild fullness in the submandibular region that is not fat, does not respond to caloric restriction, and that most seniors and most doctors interpret as submental fat without examining the nodes themselves. A physician who palpates the submandibular region carefully can feel the difference between soft, mobile, lipomatous fat and the firmer, slightly granular texture of enlarged lymphoid tissue. The significance of this distinction goes beyond cosmetic. Persistent submandibular lymphadenopathy, even mild chronic, apparently benign enlargement, warrants investigation of its source, because chronic dental and periodontal infection driving lymph node stimulation is itself a cardiovascular risk factor through inflammatory pathways that are now well established in the cardiology literature. The fourth cause is the loss of mandibular bone density and dental support that occurs with age, combined with the soft tissue redistribution that follows. The jawbone and its associated dental structures provide the structural scaffolding that keeps the lower face defined. When mandibular bone density falls, as it does with age, with tooth loss, with poorly fitted dentures that do not maintain adequate vertical dimension, and with the disuse atrophy that follows tooth extraction, the soft tissue of the lower face loses its underlying support. The skin and platysma that were once draped over a robust bony framework begin to descend and accumulate in the submental region. Not because new fat has appeared, but because the support structure that was holding that tissue in a defined position has resorbed. This mechanism is compounded by the natural age-related changes in the retaining ligaments of the face, fibrous connective tissue bands that anchor the skin, and superficial fat to the underlying bone and muscle. These ligaments weaken progressively with age, allowing the superficial fat compartments of the lower face to descend under gravity. Fat that was once in the lower cheeks migrates inferiorly toward the jowls and submental region. No new fat has been deposited. Existing fat has moved, following the path of least resistance, as the structures that once held it in place have relaxed. The fifth cause, and the one that is most genuinely related to diet but in a way that is almost never correctly explained, is insulin resistance and the specific pattern of fat distribution it promotes. I described in a previous video how insulin resistance produces cellular fuel starvation despite adequate blood glucose. One of the less discussed consequences of chronically elevated insulin is its effect on regional fat distribution. Insulin promotes fat storage and inhibits fat mobilization. In people with insulin resistance, this effect is most pronounced in the visceral compartments, the deep abdominal fat, the intrahepatic fat, but it also affects the submental fat pad. The submental fat compartment, particularly the deep subplatysmal fat, has a specific hormonal sensitivity profile that makes it resistant to mobilization under the conditions of chronic hyperinsulinemia. This explains the clinical observation that many seniors with persistent submental fat have tried caloric restriction repeatedly without meaningful improvement in the submental region, while losing fat measurably from the trunk and extremities. The problem is not that they are not creating a caloric deficit. The problem is that chronically elevated insulin is preventing lipolysis, the breakdown and release of fat from storage, in the specific fat compartment that produces the visible submental fullness. Reducing insulin exposure through carbohydrate restriction, reduction of high glycemic foods, increased physical activity that improves insulin sensitivity, and adequate sleep that regulates cortisol and its interaction with insulin signaling, addresses the root hormonal environment in a way that caloric restriction alone does not. Now I want to address what actually works for the different causes, because the intervention that is appropriate depends entirely on which mechanism is primary, and most people are pursuing the wrong intervention for their specific cause. For postural contribution, which is often the largest single factor and the most rapidly correctable, the intervention is cervical retraction exercises performed daily. The deep neck flexor muscles, which maintain neutral head position, are typically weak and inhibited in seniors with forward head posture, while the cervical extensors and upper trapezius are overactive and shortened. A program of chin tucks, performed lying flat, sitting, or standing by gently drawing the chin backward to restore the head over the shoulders, activates the deep flexors and counteracts the forward migration pattern. Research on cervical retraction exercise has shown measurable improvement in head position within 4 to 6 weeks of consistent daily practice. As head position corrects, the geometric compression of the submental soft tissue reduces and the apparent fullness decreases proportionally. For thyroid-related submental fullness, the myxodematous infiltrate I described, the appropriate intervention is thyroid investigation and, where indicated, thyroid hormone optimization. I covered the specific tests to request in a previous video: TSH, free T4, free T3, and thyroid antibodies. A TSH in the upper half of the reference range in a symptomatic patient with periorbital and submental puffiness and the other features of subclinical hypothyroidism is a legitimate indication for a trial of thyroid support under medical supervision. The resorption of myxodematous tissue following thyroid optimization can be gradual, over months rather than weeks, but it is well documented and distinguishes thyroid-related submental fullness from simple fat accumulation. For lymphatic congestion, the submandibular lymph node component, the intervention addresses both the source of chronic inflammation and the lymphatic drainage. A comprehensive dental examination specifically looking for periodontal disease, dental abscesses, and chronic gum infection is the starting point because treating the source of chronic oral cavity antigenic stimulation is the only way to allow the stimulated nodes to return to resting size. Manual lymphatic drainage, a specific therapeutic massage technique that facilitates lymphatic flow from the submental and cervical region, has evidence in the physical therapy literature for reducing submental fullness in patients with lymphedema and chronic lymphatic congestion. It is performed by trained therapists and is distinct from ordinary massage. For the insulin resistance component, the dietary approach with the strongest evidence for reducing the deep subplatysmal fat specifically, rather than general body fat, is carbohydrate restriction combined with resistance exercise. Resistance exercise activates GLUT4 glucose transporters in muscle tissue through an insulin-independent pathway, improving cellular glucose uptake and progressively reducing the chronic hyperinsulinemia that prevents submental fat mobilization. A combination of reduced dietary glycemic load and 2 to 3 sessions per week of moderate resistance training produces the hormonal environment in which the submental fat compartment becomes accessible to lipolysis in a way that caloric restriction alone cannot achieve. For the structural and ligament-related descent of lower facial fat, the gravitational migration I described, the interventions that have the strongest evidence are facial resistance exercises targeting the platysma and the perioral musculature, which slow the rate of ligament relaxation and maintain the muscular tone that provides some structural support to the overlying soft tissue. Maintenance of adequate dental vertical dimension through well-fitted dental prosthetics if natural teeth have been lost, and optimizing bone density systemically through calcium, vitamin D, resistance exercise, and medical management of osteoporosis if indicated, which preserves the mandibular scaffolding that supports the overlying tissue. Here's the summary of everything we covered. Submental fullness in seniors has 5 distinct contributing mechanisms that operate independently of total caloric intake. Cervical forward head posture compresses and foreshortens the submental soft tissue geometrically, often the largest single contributor and the most rapidly correctable through daily cervical retraction exercises. Hypothyroidism promotes myxodematous tissue infiltration in the submental region that does not respond to caloric restriction and requires thyroid investigation and optimization. Submandibular lymph node enlargement from chronic dental and oral cavity inflammation produces a firm fullness that is not fat and requires dental evaluation and treatment of the inflammatory source. Age-related descent of lower facial fat following ligament relaxation and mandibular bone resorption redistributes existing tissue downward without new fat deposition. And chronic insulin resistance prevents lipolysis from the deep subplatysmal fat compartment in a way that caloric restriction alone cannot overcome, requiring reduction of dietary glycemic load and activation of insulin-independent glucose pathways through resistance exercise. If this video changed how you understand a feature of your body you have been accepting or criticizing for years, please share it. Share it with the person in your life who has been dieting without results and blaming their willpower. Share it with the senior who has been told the only option is surgery. Share it with anyone who has been carrying the idea that their double chin is a reflection of their choices, when the reality is considerably more physiologically complex than that. Subscribe to this channel if you have not already. My next video covers the cervical retraction exercise protocol in full, the exact movements, the correct form, the frequency, and the additional exercises that address the thoracic and scapular components of forward head posture that make the cervical correction sustainable. Subscribe so it finds you directly. I am Dr. Edward. Your body has reasons for every change it makes. Find the reason before you blame yourself. I will see you in the next one.